Hello, and thank you for joining today's webinar. We will be starting the webinar in 4 minutes. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. The speaker and planning committee members have disclosed no conflicts of interest. To receive contact hours for this CNE session, participants are required to attend the webcast and complete the evaluation form, which will be emailed to all attendees approximately 1 day after the webcast. This webinar is being recorded and will be available on the Sigma repository within a few business days of recording. Following the presentation, we will have a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose, and the presenter will answer. Be sure to hit send so that your questions make it to us. To test this feature out, can each of you submit the state and/or country you are from? Also, we would like to thank our speaker, Dr. Polly Masnick, for sharing her expertise with us this evening. Now I'll turn the presentation over to her.
Thank you. I'm so grateful to be here. Good evening, everyone. To those of you who joined us last night, I hope that it was helpful to you all on the front lines as you went out to work again today. And for those of you joining us for the first time, I'd just like to take this moment to thank you for the great work that you're doing. Nurses are so respected and so needed and so valued, and your being on the front line is making all the difference in the world to our patients, our families, and our communities. And I want to thank you also for taking time tonight. I know you have to be exhausted. You're juggling work challenges, the stresses associated with this virus, and then certainly the issues that you all face as you come home, whether it's caring for elder parents or family members, having your children at home and having to do homeschooling with them, and all the things that make our work life equally even more challenging in terms of juggling your day-to-day balance. So thank you for joining us. I hope tonight we'll be able to share with you some tips that might give you some help as you take care of patients who are seriously ill and maybe even actively dying from the coronavirus, their families who may or may not be able to even be with them, and certainly the communities and the fear that they face with this particular COVID-19. I am happy to share with you that I am Research Associate Professor at Case Western Reserve University at the FPB School of Nursing. And I'm also the Project Director on Dr. Betty Farrell's LNIC project to encourage the use of undergraduate and graduate education in primary palliative care around the country. So with that, I'll move to the next slide. Next slide, please. I hope. Thank you. As we mentioned earlier, I have no financial conflict of interest to disclose, nor do any of the other Sigma people that have worked on this webinar for you. Next slide, please. What we hope to do tonight is to really discuss the role of primary palliative care. This is not specialty palliative care. This is providing primary palliative care, and the role of that kind of communication, skill, and technique to respond to the fears and concerns that patients and families are going through right now. I'm going to talk with you about 3 specific communication skills that I think might be helpful to you at this time during this crisis, and not only for your patients and families, but also for your communities and your colleagues at whatever clinical setting you are working in. And then I hope at the end of this session, you'll have been able to put together your own toolbox of words and phrases that might help you as you go forward in the days and weeks ahead, and help give you some tips to respond to the difficult questions that are out there. Next slide, please. So just to remind us, as if we don't get enough of this from the news, media, etc., but there's no question about it. This is an unprecedented pandemic. I've been a nurse for over 45 years now, and I can never remember anything like this. We're certainly living in a very rapidly changing environment. We get updates on this pandemic definitely daily, sometimes even hourly, as things change. And unfortunately, we're in a moment of time right now in the US where we're seeing the numbers rise exponentially as more and more testing is available, and subsequently the number of deaths also increase. We know that it's stressing all healthcare providers, especially nursing, and it's really asking us to come up with some new strategies to manage these challenges. And I hope that that's what this webinar will do for all of us. Next slide, please. We're not new to this, right? We as nurses are leaders amidst many, many different kinds of crises. And of course, we go back to our leader, Florence Nightingale, who in the Crimea War was instrumental in changing the environment of care and providing compassionate quality care to soldiers who were dying on the battlefield and in her care. We at this time, this is the year for nursing, and it's certainly the 250th anniversary of Florence Nightingale. So we can proudly raise our head and say we've been doing this for many, many, many years, and we can continue to be leaders in this crisis. Historically, we've been incredibly creative and flexible. And as I mentioned last night, once again in 2020, the Gallup poll indicated that nurses are the most trusted healthcare professionals. And one of the most important things in communication skills is to establish a trusting relationship. So we already have a heads up in that area. We certainly are known to be strong advocates for patients and families, and our public health commitment certainly has led us to be a strong advocate for care in our communities. And we know how to provide expert, compassionate, holistic care. We've been educated to be change agents, and we're going to use all of these skills that we have and build on them tonight. Next slide, please. So how can we do that? How can we lead the way now? Well, in every setting, no matter where you are working, whether you're in the hot spots in New York and New Orleans and Washington State and California, or in a community hospital in a setting where they're concerned about becoming a hot spot, now is the time to care for everybody with coronavirus and their families. And as I mentioned last night, over and over again, especially provide care for those who are imminently dying. Our ability to do this is challenged because many patients are unfortunately having to die alone without their loved ones around them because of the epidemic, and we recognize that we as nurses may be the only ones to be with them at this most critical moment in their life. Now is the time as leaders to care not just for these patients and families, but our fellow nurses and our other healthcare colleagues. We are all struggling. I've heard from so many, the compassion fatigue is overwhelming, the moral distress, the burnout. We've been in this just a few short weeks, and we know it's not going to be over tomorrow. So taking care of ourselves and each other is so important. And now is the time to seek out the resources and the education and the facts that are accurate, that will strengthen our ability to be able to provide care for those with coronavirus, but also to provide that compassionate quality palliative care that we'll talk about tonight. Next slide, please. So how can we strengthen our already great communication skills during this crisis? Because we are challenged. We aren't able to use some of the skills that maybe you've already learned in nursing school or in further education that you've taken around this area, because we don't have the ability to sit side by side, use touch like we've done in the past, be able to communicate both verbally and non-verbally, because sometimes we're having to do so many of our conversations on the phone. We've got to find a way to strengthen the skills that we have and adapt to the changing environment. And as we as nurses are, be flexible. So we'll share with you some of the communication skills that have been used in primary and specialty care for patients with serious illness and their families. Some of the content that I'm using tonight is from the ELNEC, the End of Life Nursing Education Consortium projects curricula, in particular the critical care curricula in palliative nursing. But a lot of it is from some of the new resources that have just been posted out there within the past week. In particular, from the Center to Advance Palliative Care, which is called CAPC. They actually have a toolkit for the COVID-19 crisis. And although CAPC is very much a membership organization, they have made all these resources available to all of us as healthcare providers at no cost. And among their resources are some wonderful communication strategies that come from Tony Bach and the other authors of Vital Talk, a palliative care expertise communication skill program that's available to all healthcare providers, but they have taken it to the next level to really bring up important points about using skills amidst this crisis. Next slide, please. So communicating with patients and families, what do we know? Well, typically what we know in palliative care is that they expect us to be able to take time to listen. And in this crisis, your time in the room might be very limited because of the challenges with being in caring for patients in isolation, having limited PPE, having to reuse N95 masks, and being very much aware of the amount of time that you're spending in the room. The patients and families are hoping we're able to do this. You can always listen, even if you can't be in there for 20 minutes. It's amazing. Keep in mind that even 5 minutes when you're doing really attentive listening can make all the difference to a patient and or a family member that you're focused on. Studies have shown us that actually, when the patient or family knows that you are listening by either pulling up a chair if you're able to fully gowned sit down, within social distancing from the patient, but letting them know that you have these 5 minutes to be in there and not just with your gloved hand on the doorknob, but being able to listen to what their concerns are and develop a rapport. And as I mentioned earlier, most times when we ask patients and families what they want in terms of communication, it's honesty. And we as healthcare providers are seeking honesty in the newscasts and the presentations and the websites that we go to make sure we have the latest information. This is exactly what patients and families want. They want honesty from us. So if there's something we are unable to do, we have to tell them. We have to be clear with what we can do and the things that we are not able to do because of the restrictions. Whenever we're communicating with them, we want to know as much as possible about the individual, that person's values and goals, and what their hopes are. And when we take time to listen, we might be able to attain some of that in every visit that we're in the patient room. They want to be informed. This is true of patients with serious illness that is not COVID-19. They want to be kept up to date on the latest. And those of you on the front lines know that patients' family members are calling, I'm sure, multiple times during the course of the day because they want to hear from you what is actually happening. How is my loved one? They want your honest discussion about what is actually going on. It's important that we are all on the same page. They're communicating with the team. So when family members do talk to different team members, and that does happen still, they're all getting the same message. And whenever possible, to be able to provide safe space for them to share their fears. Next slide, please. So what are some of the skills that our specialty palliative care folks have shared with us so that we can all deliver primary palliative care? And these three are the ones that I'm going to focus on most tonight because I think they are something that are powerful and yet easy to do, and skills that you can use at the bedside. Next slide, please. So what do we want to make sure that you're able to do in terms of attentive listening? Ideally, we want to be able to sit near the patient. Is in this picture. That's not going to happen. In most situations, you're not going to be able to do the things that we might have done as bedside nurses in the past, pull the chair right up to the bedside so that we're close to the person. We need to keep that social distancing, and we need to, unfortunately, often be gowned and using equipment that might make our conversation even more challenging. But if you need to find a way to make that person that you're talking with feel comfortable having a conversation with you, whether it's the patient or whether you're talking with a family member, keeping that distance as appropriate. You want to listen and you want to use silence. It's really important not to interrupt when they're trying to tell you something or try to change the subject. Just be still. And that's very hard to do, especially when your mind is racing, thinking of all the things that you have to do in this very busy time when you're caring for such critically ill people and running from room to room, regowning, regloving, and certainly answering multiple phone calls. It's important when you're attentive listening that you validate feelings. And you'll see many of the slides that I'll show you that come after these really attend to, validating what the person's experience is. And there's no question about it. The experience that people are going through right now is devastating and difficult and like nothing else we've ever seen. Take time. Don't jump right in to give advice. We don't necessarily have to tell them what we think they should do. We want to listen to what they think they should be doing for their loved ones and for their family members, and encouraging them to share stories that can be calming for them, as well as giving you an insight into what the person is about. So the key points of attentive listening, which I know you all know because we've learned this in school, is to be fully present, be silent, listen attentively without trying to think about what your next question is or what you need to do in the next room. And that is a huge skill to work on, especially in a very hectic, crazy time that we're in right now. Next slide, please. I particularly loved the patient-provider communication website that had some considerations for at the bedside. When I saw this, I thought it might be helpful to post this for you in terms of strategies that, sometimes we don't even think about, but we're so used to working through these protective masks and gear now, and assume that patients understand how critical they are for their safety as well as the public and our healthcare providers. But, remember that sometimes, especially our elder patients, may have some real difficulty understanding what you're saying when you're speaking through these masks. It's not that unlike a patient maybe who has some sort of communication disability. And so important to try to get the patient's attention by locking eyes, or if touch is appropriate and you're, using the appropriate PPE, can certainly do that. To speak loudly, slowly, and distinctly, and be able to use nonverbal so that you can establish clear communication, especially if they are short of breath and unable to speak at any length. Getting yes and no signals are really important, and then posting a sign so everyone knows what works best for this particular patient, whether it's a head nod or a thumbs up kind of thing, or an eye blank, but so that those nonverbals are well known to all providers going into the room. And repeat the important words that you're saying. If possible, use visuals, maybe even writing on the board in the room, or pointing to pictures or faces on a communication board. These little tools were provided to us by some of the folks that are responsible for improving communication, our speech pathologists, et cetera. But I thought that they might be helpful to remind us that, especially when we're used to these protective gear, that patients and families are not. Next slide, please. The second strategy, after the power of presence and listening, is simply ask, tell, ask. This is a great little tool that I use all the time when I was working as a nurse practitioner in palliative care in particular, because it's an empathic way to communicate with someone, but it's a simple skill to remember. It's not a really complicated mnemonic that you have to remember, now what letter was this for, etc. It just means specifically to open up with a question. And in palliative care, we typically ask either the patient or the family, what do you know about how you or your loved one is responding to treatment? To get a sense of, is their understanding of how this person is doing? One of the important points that our colleagues from Vital Talk have said, that the luxury that we've had with palliative care in the past, where we had more time to have some of these conversations, has been shortened in the aggressiveness of this crisis, and the rapidity with the speed with which patients rapidly decline from the virus. We may not have the luxury of the time to get great detail, but I think opening up with this simple question is still so important. What do you know about what's going on with you, or how you're responding to what we're doing here in the hospital, or how you're responding to, care at home, or what do you know about your loved one, how he or she is responding to treatment? And then just be silent for a few moments and let them share with you. Maybe they're going to tell you, I think he's going to be fine. He's such a fighter. He's not going to have any trouble getting through this. Or maybe that person's going to tell, that family member is going to say, I don't know what's going on. No one's telling me. Please share with me what is actually happening. And, moving quickly into the second part is the tell. After listening attentively, that's when you want to share with them what the truth is. So rather than just going right into the room and sitting with the family member, or being on the phone with the family member and just cutting right to the chase, you've asked to get a sense of what they think is going on. And now you can craft your response to that, depending on how that person has given you an answer to the first question. And so after listening attentively, respond as to what you know is the truth. For example, it's my understanding that coronavirus has made your dad really seriously ill. And it might be that you're having the conversation right now in the ICU, where they are at a point where they have to start to talk about withdrawing technology. Notice there that I said withdrawing technology, not withdrawing care. We never, ever, ever withdraw care, right? We as nurses always provide care. We might stop technology that's no longer helpful. We might not start technology that wouldn't be helpful, but we never withdraw care. And so being honest with the person about, your loved one is seriously ill, even using the word death or dying. And, we are at a point where we need to talk about next steps and whatever those might be. And then wait for the family member to respond and listen again attentively. And then the final ask is just to make sure we haven't missed anything, and end with an open-ended question to allow that family member to add anything else that needs to be said. So at the end of a conversation, you might say, knowing what you know now about how close your loved one is to end of life from this coronavirus, what is most important to you and your family? And then hopefully we can act on those things that they are hoping for. So ask, tell, ask, a simple strategy that can be incredibly powerful. And it gives the patient or the family member that you are using this skill with the sense that they've been listened to attentively, that they've been heard, and that you are responding honestly and truthfully to what is going on. Next slide, please. And in the midst of all this, my third point was to maintain hope. There's always hope. Hope is essential for coping and finding meaning. We know that. And many times we as nurses and other healthcare professionals too hear family members say, well, we don't want to lose hope, or we don't want to tell him that he's dying because we don't want him to give up hope. But we know, in fact, that typically patients often know things are really bad. They know that if they're dying, even if they don't say it to their family, they're often trying to protect them. With the acuity of this illness and with all that's on the news, et cetera, people who are seriously ill in the ICU or seriously ill in the hospital with coronavirus and also have other comorbidities most likely are very aware that they are at risk of dying. And even if they don't say it, or if the family member doesn't say it, they're thinking it. And maybe it's very true that there is not a hope for a cure for a particular patient. We can't fix everything, and we know that patients are going to die from this illness. But there is always something to hope for. And so even if the prognosis is very poor, as you're talking with the patient or the family, even, sharing with them the fact that if we cannot cure you from this coronavirus, what are you hoping we can do for you? And then see what you can do to try to help the patient or family accomplish that goal. This is especially challenging when there are so many visitor restrictions, because often what the patient or family member might respond is, we just want to be with our loved ones. And so assuring them that, you will ask if an exception can be made, helping them to understand why those rules and regulations have been put in place, and then finding some creative strategies to help them feel as if they are present with their loved one, either using iPads, iPhones, technology, sharing taped messages, etc., whatever you can do to help the patient or family accomplish the goal that they have verbalized. Next slide, please. Some of the key communication skills from palliative care that many of you may already know, but I think it's always great to just remind ourselves of what those techniques are. As we've mentioned and keep stressing, building trust is critical. Another one of our favorites is giving a warning shot. This is so true if you're having to answer the phone and maybe the patient has just taken a major turn for the worse, and there's no one else to share that with the family but you as the nurse, and you've got to give them a chance to get ready. One of the ways to do that is to say, I regret I have some difficult news to share with you. Obviously, we hate to do that if someone is home alone and doesn't have support. You can certainly ask if they have someone with them, or if they'd like to wait until someone comes, if that's even feasible with these restrictions. But you've got to prepare them that the news that you're going to share with them isn't good. And acknowledge the emotions. We keep saying that over and over, especially with this crisis, legitimatizing the normalcy of reactions to the difficult news associated with this virus, whether the patient's been transferred to intensive care or being sent home with hospice, or just receiving the news that they have tested positive and are critically ill with this disease. Acknowledging that anyone getting this news would be upset. In this day and age, it is incredibly frightening. You can ask what's underneath the emotion, what is worrying you most right now. It may be that I'm going to have to be in the hospital, and maybe the patient will even share with you, I never wanted to go to the ICU, and I never wanted to be ventilated or have those CPR done to me. That's important information to hear about and know about, especially as you're working with the team to plan care. Certainly be empathic. I don't think I have to tell any nurse that. Letting patients and families know that, we can't possibly imagine how overwhelming it is for them. We're not in their shoes. Letting them know that we're here for them, and then helping them to dig deep to where their strengths are. None of us have ever coped with this kind of a pandemic before, and certainly when you're talking with patients and families, they haven't either. Ask them where they found strength in other challenges that they might have had in their lifetime, whether it be a different type of death in the family, a divorce, a loss of a job, whatever. What gives you strength? And then, hopefully help them to use those coping skills and strategies to get through this difficult time. And of course, continue to emphasize the importance of listening in silence. So you see the big ones on this page: trust, acknowledging emotions, using silence, and certainly being compassionate and empathetic are critical. Next slide, please. as we continue on with other great techniques that our palliative care colleagues have shared with us is, when we are giving information, especially to patients, family members, want to make sure that what we've shared with them has been heard, and then making sure that whatever we have talked about, that not only that they understand it, but is there anything else that we didn't talk about that's worrying them or bothersome today? And using the D word, letting them know if in fact it is true that they are close to end of life, it's okay to use the word death and dying. They're looking for you to be honest and truthful, and it gives them the opportunity to put some plans in place, especially given the restrictions that we have in visitation. How are they going to be able to say the things that are important to their loved one? I love you, thank you, goodbye, all the things we know are so critical, end of life tasks to be able to accomplish for the patient and also for the family. No question about it, we're expecting conflict. I heard questions last night about family members being angry. We can expect that that's going to happen. It's frightening, and people, of course, respond with anger and fear when they are struggling. Summarizing and restating what the patient has said so that everyone is clear, and making sure that they all know that we will continue to provide care to you, that we're not abandoning you. And that's never been more important than now, because people do feel abandoned in this crisis, especially if they've tested positive. Next slide, please. And then specifically, as I mentioned earlier, when the end of life is approaching, it's important to have those discussions as soon as possible and to be honest. Because this has a very rapid trajectory, we want to give families time to do any of that important anticipatory grief work that they can do. We certainly want to let the patient have the opportunity to say their goodbyes if we can do that, and we want to be able to support them in the things that they are hoping for as they plan this difficult death. There's a great website that I posted there for you on talking about benefits and burdens of treatment options. I know that's often fortunately a responsibility of the whole team to discuss that, but it's not unusual for nurses to be asked these questions by patients or families, especially in terms of the ventilator. And, what does that mean? And so being prepared to clarify those benefits. If you need some extra help, Vital Talk is great. Next slide, please. And as I mentioned very early on, to give you some tools to put in your own toolbox, CAPC has just done a great job of putting together a website that helps all healthcare providers with the challenges in communication. I've added some of that to our slides, with the, certainly the symptoms that we're commonly seeing in this crisis, including dyspnea, cough, some of the respiratory struggles that are so difficult. There are great recommendations for symptom management. There's patient and family support resources that come from the CDC. They have a very nice section on how important it is, if you have the access to palliative care, to certainly tap into that. The team, if you have availability of that at your facility, use them, call on them. Their interdisciplinary approach will attend to the mind, body, and spirit of the patient and family, and also to your team. And they have a whole section on guidelines for care. It's a great resource, and I hope it's helpful to all of you. Next slide, please. And I mentioned that Vital Talk, our colleagues who have done that, tremendously helpful in palliative care. It is heavily written for physicians by physicians, but you can substitute nurse in for almost all of those physician words and recognize that, we are doing all of this as well. And there are tips that are specific to conversations around COVID-19 are particularly helpful. These communication skills are also on the CAPC website, and I'm going to show some of them to you in the next few slides. Next slide, please. One example is when you are being told that someone doesn't want to be in the hospital. Maybe this occurs in the emergency room setting when someone comes in with a question of having the virus. They may say to you, I have other problems in addition to this virus. I want to take my chances and go at home or in long-term care. And Vital Talk gives us some words for how to respond to that. They do want to go home, or they want to remain in their long-term care facility rather than be admitted to the hospital. And you can see in bold, they're clarifying what the patient is saying. What I'm hearing is you'd rather not go to the hospital if we suspect that you have the virus. Did I get that right? And getting that clarified really helps in terms of identifying goals of care. This is a person who does not want to be admitted to the hospital and subsequently to the ICU should they get critically ill, and recognize that they're not that medically well even without the virus and don't want that. So honoring and respecting that so that that person would be able to stay in the long-term care facility or be at home is important. And palliative care can help you with that if the team that you're working with is struggling with it. Next slide, please. What happens if you're doing some of the work in triaging? Again, those of you who are in outpatient settings doing this work or rooms, and the patient maybe will be saying, I'm feeling so terrible, I'm so scared, I really think that, even though I'm not struggling to breathe at this point, that might happen down the road. Why are you keeping me out of the hospital? And their recommended response, is letting them know, again, acknowledging their fears. I imagine you are worried. I can understand that you are very frightened by this, but right now, the hospital has become a very dangerous place unless you really, really need it. And the safest thing for you to do is, and probably will be to, self-quarantine at home and call us if, your symptoms progress. Next slide, please. How about when you're involved in a patient being admitted, either directly to the ICU or to a hospital bed? And what if the patient or the family says, how bad is this? And again, they're looking for honesty. So we want to tell them, based on the data that we have, what we think is going on. And maybe you as the nurse are going to say, based on my assessment of how things are going for you and my listening to your lungs and examining you, your situation is serious enough that you need to be in the hospital. We'll know more in the next day. That's being honest with them. How about when they ask, in fact, a family member says, is my loved one, or in this case, my example of, is my grandfather going to make it? Acknowledge the fear that's in that question. I imagine you're scared. I hear you being really worried. And then, being honest. As you see in this response, it is quite possible that he might not make it out of the hospital. If you don't know for certain, honestly, it's too soon to say that. And then what happens when the patient says to you, the nurse, are you telling me no one can come and see me in the hospital? This is horrible. I don't want to be alone. I feel, like everyone is abandoning me. Responding that, it is hard not to have visitors. And I am so sorry to say that, right now we cannot allow visitors. They will be in more danger if they come into the hospital. Share wish statements with them. I wish things were different. Well, we all wish things were different. And then give them some strategies. Let me help you. You can use your phone. I know it's not quite the same. Let's see if we can get an iPad in here so that you can FaceTime and see the person as close as you possibly can and have some visitation that way. And what happens when the family member says to you, what do you mean I can't come in? How come you won't let me visit? Again, telling them, acknowledging this is so hard. It's really hard for you not to be able to come in. I wish I could let you visit, but it's not possible right now. And that, the risk for spreading the virus is so high. I'm sorry to say we can't let you visit. What we can do, though, is we can help connect you electronically and then look into the technology. Next slide, please. So what about when things aren't going well? What about when it comes up, in terms of, goals of care and code status? It's never been more critical than now to get that clarified as quickly as possible because this disease progresses so rapidly. You really want to know what's important to the patient and or what the surrogate is sharing, what would have been important for the patient if it could verbalize for himself in terms of goals of care and code status, ICU admission, and ventilator support. And we saw that in one of the earlier slides when a patient said didn't want to be in the hospital, wanted to be able to go home, didn't want all of that technology. Certainly, that's important for us to know. And when the patient or family member says, I don't want to end up a vegetable or on a machine, asking a little more clarification, can you tell me more about that? And acknowledging it's so important to know so that we can honor and respect their wishes. But what happens in the first sentence when someone says, I want everything done, I want to live? Or my favorite is when, someone very quickly asks a family member, do you want everything done for your mom? Well, who's going to say no to that? What a really not helpful question. Of course you want everything done. That's possible. What needs to be asked is, is the question not so much, do you want everything done, but I need to know more about your loved one or about what your wishes are so that we can have a treatment plan that matches your wishes. And then acknowledging that, we are always doing everything we can to take care of you. What do we need to know about you to make sure we're taking the best possible care of you? So please discourage our colleagues from asking when they're rushed to ask the code status, do you want everything done for your loved one? Of course they do. They need to be very direct in terms of we need to have a discussion about what to do if their heart stops or their breathing stops, and we need to talk about the use of the ventilators. There are other examples there in terms of, when the surrogate or the spouse is responding for the person, if they aren't sure what the patient would have wanted, they don't have advanced care planning pre-done, they don't have an advanced directive, a MOLST or POLST or anything that's already been in writing, we can take a moment and say, let's talk about what they would have wanted. Tell me, what was important to them in their life. Was there ever a time that you might have had a discussion about what your loved one would have wanted if he had a critical illness? For example, when an aunt was ill, or you watched a TV show together and you watched someone go on life support, what had you made shared that would give us some guidance into terms of what they would have wanted or considered to be important for their life. And certainly many patients don't necessarily want a breathing machine or CPR. And if they knew honestly that they might not make it through that, which we know those who have serious comorbidities, the chance of them leaving the hospital after resuscitation are very, very, very slim. They wouldn't want to go through that whole ICU experience if it meant that they would not make it and it limited their ability to possibly even see their loved ones before they died. Next slide, please. And what about, we talked a lot last night together about moral distress and all the grief that we as nurses are are experiencing, as well as that grief that we're witnessing from patients and families. Want to make sure that, if there is death and loss and grieving, of course, is occurring, if you know that maybe your colleagues are struggling, for example, saying, like, I should have been able to save that person, what can you do to help support your colleague who is struggling with, I can't believe that that person just died? Step back for a moment. Think about, that statement. You did everything you could to care for that patient. It was the coronavirus that killed the patient, not you. And make sure that when you are thinking, I should have been able to save that person, you would respond to yourself the same way you would to your colleagues. You're exhausted, you're overwhelmed, you're sad. All these feelings are normal, but you've got to tell yourself, I did everything I could to care the best I could for that patient in this difficult, challenging time. And then what happens when a family member says, on that phone call that you have to make, I knew this was coming, but I didn't realize it would happen this fast. Again, they're experiencing acute grief, acknowledging the sadness and how shocking this must be, and then be silent, allowing for them to gather their thoughts and restart the conversation. Next slide, please. So my wish statement for all of you was that your patients and their family members could be together like this, especially as their loved one is coming close to the end of life, that they could have the opportunity to physically touch one another, to share the words that they need to say to each other, to be able to perform the rituals and important cultural experiences that are so critical to their end of life passage. I wish that everyone would be able to have this kind of experience, but we know that with the PPE, with the limited restrictions to visitors, all of that has changed tremendously for us. So we as nurse leaders have got to come up with ways that can help our patients and their families have a death experience that is meaningful, that is limited in complicated grief, which we're going to see from this epidemic, and that will leave memories for the family members after the loved one's death that are much more positive than negative. Next slide, please. I'd like to end with just taking a moment to thank all of you for the great work that you're doing. It has to be incredibly scary to be on the front lines, those of you who are in the hotspot settings across our country. It has to be overwhelmingly exhausting. And I can't imagine what so many of you are going through as you experience shortages of equipment and testing, et cetera. On behalf of ELNIC and Sigma, I thank you all for the great work you're doing. I wish you all safe days ahead and healthy days ahead, and would open up our last few minutes together for questions or discussion.
Polly,
Next slide. Yes, the
I
next
was,
slide.
sorry.
Simply references, that you can access for what we've already talked about, and then finally, opening it up to discussion. Thanks.
Yes, Polly, I have a few questions for you. Someone said, I think one thing nurses are prone to saying is, I'm sorry. Should nurses use I'm sorry or try to say more I wish statements?
Oh, thank you so much for saying that. We always want to, we've kind of been brought up to say, I'm sorry. And that sounds like we're taking responsibility for this. And none of us are responsible for this, as no one is. So using those I wish statements is a wonderful palliative care skill that takes away blame, and lets the person who you're sharing that information with know that you really do wish that things were different, or you hope that something would happen for them. Those I wish statements are very powerful. Um, you'll notice that in most of the conversation examples that I gave, there wasn't the word, they didn't begin with "I'm sorry." They acknowledged the emotions and then, many times said, "I wish things were different." Great point. Thank you.
How do we strike a balance between being honest about imminent death and staying within our scope of practice if no one else on the team, including doctors, has been clear about the poor prognosis?
That's a question that is commonly asked by many nurses, and those of us who teach LNEC for the past 20 years, regardless of the type of serious illness, whether it's coronavirus or heart failure or cancer. That's a very common question in terms of what can nurses do within their scope of practice. If you go to the ANA scope of practice for care of the dying, you'll see that honesty is in there. It's listed. It's very important. So if you're uncomfortable with using the actual words as I showed you on some of the slides, based on what I'm seeing from my examination, or based on the changes that I've seen in your blood, in your loved one's blood pressure or breathing, etc., based on the fact that I'm seeing some of the signs that we typically see when death is imminent, I believe that your loved one is dying, and it's okay to share that with them. It is being honest, and as you'll know from our scope of practice, that is acceptable. For people that are concerned, or maybe you're in an institution where the nurses are a little more restricted in their practice, for whatever reason being, you can be creative in the way you address that issue. And if a patient, for example, says, "You don't think I'm dying, do you?" when in fact as a nurse, he has all the signs of imminent death. He has coronavirus and multiple comorbidities, and he's 89 years old. Chances are very strong that he is dying if he's asking that question and he has those aggressive symptoms. Ask the patient, that's a really important question. What makes you ask that now? What are you experiencing? And then use that silence. Be quiet. Let them tell you. "Well, gosh, I've noticed nobody's ever coming in anymore, so something's really wrong." Or maybe the person is so ill he can barely respond other than saying, "I've never been sicker in my life. I can hardly breathe. I think I'm dying." And then acknowledging, that "I wish things were different. I think you are too. And if that's the case, what is most important to you right now? What can I do to help you um, as you are facing this really important part of life's journey?" And see, hopefully you'll be able to give them something that they're hoping for. I hope that helps you.
Polly, you touched on this earlier, but in your opinion, if family isn't at the bedside, how is the best way to communicate with that family that their loved one is dying?
So we mentioned in one of the early slides, one of the most important things patients and family want are information. Especially when we talk to grieving family members, they say, "I wish people would tell us more or keep us updated." And I know that's a real challenge for those of you who are, have a very busy assignment during the course of the day. If you could be honest with the family members up front at the start of the day, in terms of, "I will communicate with you if there's any sudden change. Otherwise, I will be in touch with you at such and such a time," that you can jointly set so the person can anticipate you're going to call them and share with them what's going on. Um, and you can be honest with them too, that this is, "I will call you then. If anything unusual happens sooner, I will call before then." But hopefully that will cut back on needless calls, every hour for updates if they know, in fact, you have a plan in place for when you're going to talk to them, and then you're able, hopefully, to follow through on that plan, that nothing catastrophic happens at that set hour that you've planned on.
How can we encourage patients and families to maintain hope when they are aware that death is the end result?
So you need to ask them, given the prognosis that death is imminent, what are you hoping for? You need to find out what they're hoping for, because you don't know what that is. In palliative care and more chronic illnesses, we often ask that question when we've shared with a patient or family that the treatment they've been receiving, especially for cancer, example, is no longer working, and there are no other treatment options that would be helpful. There's always hope. What are you hoping for? And so asking that question when they're imminently dying is really critical, because maybe there's something that you can do for that person and that family that will stay with the family for the rest of their life. Maybe it's an opportunity to have a phone call with a long distance relative across the coast that they haven't talked to in years, and they want to reconcile with them before they die. I think what I'm trying to help you understand is that hope isn't always cure. Hope is what the person might express it as in light of no cure. And we don't know what that is unless we ask the patient. It might be hoping to see your daughter be married next weekend. Maybe that's something that's possible. Can we do it through Zoom? Maybe it's hoping that you'll live through the night so that the next day you can have that anticipated call with your family member that maybe you've been estranged from. There is always something to hope for. You have to help that patient or the family member find out what it is, and then be creative in helping them achieve that. And so by asking, if cure isn't possible, what else are you hoping for? I think for all of us dealing with coronavirus, the struggle comes when the family member, as I said before, says, I need to be with my loved one, or the patient says, I want to be with my family, and I want all 10 family members in my room. So again, then, if that's not possible, what can we do? I'll go to bat for you to have 2 family members in your room at a time. Everyone else will have to wait outside. We'll bring everybody in via Zoom or some technology. Thank goodness we have that available now. We never had that before. And it's amazing what that can do to help support, especially people who are far away and can't travel to their loved ones, or for people who just can't come into the hospital because of the restrictions, and they might be right outside the window. Maybe there's a way for someone to stand outside the hospital and to be able to wave from that window. Who knows? Be creative depending on the scenario. Find out what they're hoping for, and then try to help them achieve it.
Polly, for those nurses who lose patients, how do we insist that they take time to process that loss rather than just getting back there on the front lines?
Oh, yes. Thank you for asking that question. We talked a bit about the fact that, yesterday on the webinar about self-care, that we have to take care of ourselves. And we certainly have to combat compassion fatigue. And you're going to see that with cumulative loss if you don't have the opportunity to grieve each one of those individual losses. Every single one is special. And we're being called on to quickly move on to the next patient, fill that bed, etc., without the opportunity to grieve the loss. In the very old days when things were so different, and early days of a hospice nurse, we used to put a rose on the patient's bed for 24 hours to honor the person that was there. Well, those days are long gone, but this is even more difficult now with this pandemic in terms of the need for hospital beds, the need for ventilators, et cetera, and the rapid turnover. We're even setting up, makeshift morgues to be able to quickly move patients out. So I guess I'm calling on all of you to find a way to put a rose somewhere, and that's not literally. It may be creating some sort of a wreath in your lounge where you can paste up the name of a loved of the person that you cared for. Maybe finding a way to remember all of the people on your unit who are dying and will die. Is going to be critical to our dealing with complicated grief, because we know that there are many people that are going to die in the next few weeks. So think of a way to place a rose or create a tree or a wreath of of memories, so that you can honor that person. And if you weren't on the call last night, we did have a video on last night's webinar that is going to obviously be posted in the repository. And the video is called The Pause. If you've not seen it, you can Google YouTube and it will come up. And it's a beautiful way to honor, take literally a pause, 2 minutes to honor the person that you cared for, somebody's husband, somebody's father, somebody's grandfather, etc., and to acknowledge the great work you did in taking care of them. If you don't take those couple moments out before you move on to the next patient, you're going to bring all that home with you, and one day all that cumulative loss is going to explode either in your clinical setting or in your personal life, and it's going to be overwhelming.
Holly, I just want to thank you so much for all this great information tonight. Sigma is grateful that you took the time to share with this audience, and we look forward to hearing from you in the future. Just a reminder to our attendees, please comment the state or country you are from through the questions feature. And thank you to our attendees for joining us. Have a great evening.
Good night.